It's time for our first panel. And our first panel is going to be talking about electronic health records. We have in the panel Jennifer Andrew from Plunkett and Cooney. She's an attorney. Also attorney Dan Baer from Kerr Russell, as well as Dr. Fabian Fragoli from St. Joseph Mercy, Oakland.
Okay. Well, good morning. I'm Daniel Baer. I'm with Kerr Russell, and we have a presentation for you, and it's going to be a little bit tricky because I'm going to try to look behind me and go through my notes here. Okay. First, I would just point out that this area, electronic medical records, is it's sort of a new frontier for all of us. We're all kind of learning as we go. And from our perspective, I think we're all prepared here, my colleagues, to comment on and make comments about these. A lot of these are going to be admittedly anecdotal, as this has come up in our respective practices. So I would encourage any of you that have any questions or comments, or even your own anecdotes, to shout them out, or if you have questions, we'll do our best to respond to those, because at least when I'm in your position, a lot of the times when I go to these presentations, I have these little terrorism or sort of terrified thoughts in my head about a particular issue that I would appreciate some assistance or guidance on. So I encourage you to do that. And frankly, I think maybe all of us here, I think I speak for all three of us, we have no problems with answering your questions or responding to them. So the first slide here is a snippet from the Michigan Lawyers Weekly that occurred probably about a year or so ago, and the phrase at the bottom, which I'm not sure is totally legible, and from the people in the back, I'm sure it's not legible, says that electronic records have opened a new realm of med-mal liability. So we had some ominous comments, and one of them was from a well-known plaintiff's lawyer in town, Brian McKean, who made a comment that these are now a danger in a world, and the world was a safer place with handwritten charts. And a lot of this, I think, is somewhat overstated and overblown, and the issue of patient safety being the component of medical care is a topic for another discussion at another time.
Just to insert that for a moment, obviously that dovetails into the reptile theory that many of us are probably familiar with, that McKean's trying to make the records issue now another issue in the reptile theory, again, to try and dummy down medicine and make it one of safety versus judgment.
So his quote there is that the advent of medical records has shifted the interface between the physician, or as we sometimes call them, healthcare providers, away from direct patient contact and shifting toward a keyboard or a menu, and that this loss of interpersonal contact feeds into this argument that electronic medical records, not being the panacea for improvement of care, are now becoming a liability and, in fact, diminishing care, which I think is we'll talk about it in a few slides down the road, is really an issue of whether claims increase as opposed to care being decreased. And another plaintiff's attorney, Chad Engelhardt, noted that the comment that keyboards are now as important as scalpels. Again, comments about the trend in some plaintiffs' attorneys' claims to make this one of the arguments, and the reference to default settings and false information being put into chart. And we can talk a little bit about copying and pasting now if that's appropriate. But the issue is you now see these charts that are printed, and they have multiple duplicative material that is not as focused on the particular encounter with the patient as what actually occurs. You see this multitude of material.
So if I can just comment, one of the things that we have, physicians don't go to medical school and residency for the purpose of, for a love of documentation. I mean, it's the fact is that We love patient care. We love to take care of people. The documentation is almost the afterthought. But in the world that we live, it becomes a very defensible document, one that helps protect us as well in an environment that is sometimes a little contentious when outcomes aren't perfect, right? Or there is a concern about the way the care is rendered. But I think what has happened over time, and I think with the new millennial generation coming in, I don't think the keyboard is going to be the primary issue, because there's so much keyboard in their lives and younger people today that interface is less of a problem. And it's actually appreciated, and there's a comfort level as we see residents documenting, not an issue. It's the later generations, those that have been in practice for a long time, and when we implement an electronic health record, whether in an office or in the hospital, the skill that's lacking is not the medical knowledge or the surgical skill or whatever, it's the ability to type. And that is a critical skill, because the quality of that document, that medical record, is limited because of the information. If I can't type and I struggle just putting in a username and password, can you imagine typing a progress note or a consult? It's just ridiculous, and it's so time-consuming. I'll spend most of my time with the documentation and very little time with the patient, and now we have a flip. And that's exactly what physicians don't want to do. But it does create a problem. And the copy-paste feature, as Dan mentioned, becomes a very convenient way to populate information. And I'll leave it at that. But that's the dovetail where we see the rub. I think it'll get better as time goes on, as people are more comfortable with using electronic devices like computers. But anyway, that's my comment.
Just to add on to what Dr. Fragoli said with the copy-paste, I'm sure we all know what we're talking about, but it's literally taking an entry from the day before and pasting it onto the next day, or hour by hour. Included amongst my client base is a national extended care facility or nursing home, and I see it a lot in that setting. You need to be particularly cognizant of it with certain types of practice where the people are overworked. The conditions don't change much from day to day. They're being asked to track everything from how much input, output, bowel movements, how much did you eat? I mean, it's an enormous amount of material, and the tendency to want to copy and paste is there. But you really need to counsel those clients, or if you're in that healthcare industry, to be very cognizant of not copying and pasting. Yes, sir?
Another thing you said in passing, Laura, was printing the record. And I found that to be very problematic, because the record isn't really intended to be printed once it's in the computer. And I know right now, at least, that's a requirement for the legal case. But I've found instances where the printed record is almost uninterpretable a lot of the time, and it seems like we're not allowed as experts in its use. I was the CMIO at the DMC, to be able to come in and actually show it live and the way it was supposed to work. The example I have is a case in which the problem list in Cerner is associated with the patient, not with the encounter. And so as things get added to the problem list, when you print it out, the existing problem list gets applied to every back encounter.
Yep.
So it made it look like a physician had falsified and added a problem onto an old encounter when really that wasn't the case.
That's a really excellent point, and I think if there's, among the many things that we're encountering in dealing with EMR in the litigation context is in what I like to call the old days. You'd have a physical chart, okay, and you'd have a form, and the form would start like this, and you'd start to write on it, and then that form or that progress note or that page in the chart would have this additional data put on it. And what you would have copied for litigation purposes would be those papers. But we have now a circumstance that the printed material that we receive, as we as defense counsel, and we say, give us the chart, get the chart, what we get in paper, on paper, isn't what is being seen on the computer screen when the actual data that we now receive on paper is given to us. So it's not the same thing. And it's often the case that when I'm meeting with clients and I have them bring the chart, and a sheaf of paper is brought, and then by the way, there's an additional computer screen that I can't really print, and it has this other information, so you're kind of left with this sort of sense that you're not on the solid ground you'd like to think you're on when you feel you have the entire record, because there might be something floating out there. And I guess the best comment I would have is just be aware of that and be prepared to ask questions of your clients, or if you're a physician, mention this to your attorney, because many of us, or most of us, we don't deal with electronic records in our practice generally, in the sense that we're inputting data, and we have a mentality that whatever we have in our computer systems can be printed as it is on the computer. So our mindset is not where yours is. So I think that's at least being able to ask these questions so that these concerns can be addressed. And I'd like to pose this to the panel, but Chad in this comment makes a comment about EMRs make it easier to detect an altered medical record. And I thought that was an interesting comment. I'd like to maybe get your insights on that. I'm going to put you both on the spot a little bit to see how you might respond to Chad's comments in that regard.
I think he's accurate. Again, in the old days, I hate to say, many of us probably remember the drive up to Lansing to meet with Lieutenant Spakeen, and you'd take your records, praying as he stuck them under the microscope, and he could date the ink that was done, the pages, the impressions would lift up, and you'd sit there nervously waiting to see if he was going to say that your client had altered the records or when certain entries were made. Now we're routinely getting requests for metadata trails to show when things were inputted, if someone went in afterwards and added something or changed something. And the author, every time someone opens a chart, your name is in there as to who opened the chart. A lot of the HIPAA cases that I defend come in because it shows someone who should not have been in that portion of the record or even have access to the records opened the chart. So I think he was absolutely on point.
Well, as a segue into this, I brought a little, this is a paper anecdote, so to speak. And the issue of audit trails and when persons access the records and when they have ability to look at them, and the issue of when items are done is really becoming a almost routine request from plaintiffs' lawyers. This document I'm showing you here is 19 pages, and it's an audit trail from an actual case that I'm involved with, involving a 3-day hospitalization at a local hospital here, and it shows all the persons who access this chart and when they access the chart. And I would say to you that this is something that gives persons the opportunity to get an idea of when they knew information and how quickly they reacted to it by identifying when they went into the record and what could have been available to them at the time they went to the record, and then when they actually documented whatever they did in that record. So it is sort of a two-edged sword, because this can also show a nice roadmap for when the care is proper, because the care is proper and appropriate and good in the vast majority of the cases, of course. So
Dan, could I add something to the comment by the physician earlier and yourself about what is the record? And I know it's coming up in some slides we have, but again, one of my hospital clients, to address the physician's point, said it was imperative when we produced the records to try and do a screenshot of what the doctor initially looked at versus how the record ultimately is printed. And we did that from the get-go, so there wouldn't become credibility issues later in terms of producing it now and then producing it later. Also, it's important, whether you're the healthcare provider, I think, or the attorney working with them, particularly during this time period of transition, to make sure when there's a request for records that if there's an electronic portion, you ask, is this all the records? Sometimes you just get the hard copy. Sometimes the prescription is all electronic, and they don't produce what could be a vital part of the record. Again, thinking to my nursing home clients, The MDS sheets, in terms of the daily input and what is being tracked, that's all electronic. But there's another paper chart that takes care of other issues. But you need to make sure you have the entire chart printed from the get-go and produced.
And then in this same Lawyers Weekly article, there was a comment by Paul Mannion, who's a well-known malpractice lawyer in town here who...
Defense.
Defense,
Yeah.
yes. That's from the defense. So, you know, with a reference to being familiar with the program, the larger institutions that require training, and then all persons who use EMR need to have persons who are familiar with this, not only for the accurate information, but the completeness of the record.
And I think when we were meeting, Dan, and talking about what we're going to say, Dr. Fragoli mentioned training as imperative in terms of what you were undergoing.
It is, yeah. So, you know, we spend a lot of time, particularly with our residents and our medical staff, in giving them the tools to really understand and how to navigate the electronic health record. The thing is, I think with the current versions of the electronic health record, there are places that you can document, and there is somewhat of a silo of information. Nursing documentation can sometimes be siloed from physician documentation, and that narrative, that story is somewhat lost. And I think it's difficult, obviously when you're caring for the patient sometimes, and then it's even more difficult when you're trying to piece a story together from a paper record to the comments that were made earlier. And so, you know, we try to spend a fair amount of time using training programs for our residents and our medical staff and our nursing staff, of course, as well. But it's really about understanding how when a document is modified, how to best modify it so that you have good transparency of information and that it's very clear if there's late documentation that's put in, that it, aside from the audit trail that's present, just so that it's very clear to the person who's reading the record in a contemporaneous fashion that it is a late entry or whatever the case might be.
And of course, the documentation issues, and this actually goes back to the non-EMR era. All of these issues are very critical in the defense or prosecution of a medical malpractice cases. How well are things documented? Is the documentation clear? And all of these things still apply. And I would add that with the advent of EMR and the availability of programs that we have in our offices, our office practice is the word search capability with EMR on at least from my perspective, is much easier because you now have a greater number of records that can be integrated into your computer system for word search. And for example, if you have a case and it's a lengthy hospitalization or it's a number of hospitalizations and you have thousands of pages of records and you put in a couple of phrases or word searches to see when, for example, the patient complained of angina or some other component, you can find these terms more readily, and I think that can assist in creating an outline for your evaluation of the case or examination of witnesses. It's a two-edged sword because if there's no reference to a certain comment, that may be a bit detrimental as well. But I think the word search capability, at least in my experience, has been helpful in getting through these massive records that, when they're printed, are probably 3 or 4 times larger than they would have been before. Yes, someone had.
At the same time, I think that could be hurtful or harmful depending on how you use it. Again, technology is a tool, and I do primary care, so we have to do, in my office, we have to do all this extra, what I call docudrama. You know, the GFI has to be added.
Right.
You have to include that you've looked at the GFR, and yes, that's helpful, but after a while you have this long list, and if I were to search that in any given chart, I could be busy for hours and hours on end, or you can see that there are, 2,000 instances of this phrase in this chart. So again, I think it's how you use the tool that matters. And some of what we have to do as physicians is not useful in terms of caring for the patient. And I see that as a more than just a two-edged sword here, and when it comes to the potential.
Well, from my perspective, when I'm looking for particular facts or non-facts, as it were, that search issue can come up. And it is a challenge because you may pick the wrong term and you are going to run into this, like the phrase BMI, it might be just a category as opposed to what the actual figure was at a given point that makes it challenging. So,
I think there's a question.
oh, I'm sorry. Just shout them out. So.
I'll stand up. Over at my hospital, we have medical scribes. So discrepancy between what they document, by the time we actually review it, there's a lot of things that they write that sometimes the patients don't really say. So how does it come into like, when we get scrutinized? You guys look at the records. Are we liable for what they wrote?
Yes.
Yes.
Or is it when it's after it's reviewed, it's signed?
Yeah, it's your document.
Yeah.
You're the final authenticating entity with the license. So what they're an unlicensed person. They don't have any sort of clinical, but most of them anyway. I don't know in your situation, but most don't have any sort of licensure at all. So they are just basically taking what you and the patient are, in a witnessed environment, right? They're just documenting what they're hearing. But at the end of the day, it's your signature, and you're taking accountability. And I can't speak from a legal
No,
perspective.
you're absolutely right.
But you're taking responsibility for that note.
The doctor's absolutely right. I see it a lot with my ophthalmology cases. I don't know if it's because the ophthalmologists are trying to keep their hands free, but they're talking out loud, and a non-licensed person is writing down the notes. And as Mr. Wolfmeyer could probably tell you, because he's the pro in ophthalmology cases, the ophthalmology terms can get pretty convoluted, and you need to, because you are ultimately, the buck stops with you. It's just like if I dictate something to my secretary, if she gets it wrong and I sign off on it, she's not going to be sued, I am. But you need to, if you're using a scribe, to get in the habit of looking over exactly what they did, hopefully contemporaneous with when you dictated it or said it, because you will be held responsible.
Yeah, it's part of this training that was that Mr. Mannion alluded to in his comment. Yes, sir.
Yes, somebody has made the mention of Cerner, and of course Epic is one of our major hospital-based. Dr. Cavoli, I think, has touched upon what I think is the most critical issue, is that we're required to review it, and then you can make a late entry.
Correct.
Does that significantly reduce the liability issue in respect to the attorney's ability to review the record?
Well, the late entry is one of those, sort of dilemmas, because on the one hand, you don't want it to look like you've added things after the fact, but at the point, if it's a legitimate, true, accurate change, it's documented that's when it's done, and if this is done, reasonably soon after the initial entry, I mean, that's a more defensible proposition than putting no entry at all, because if there's no entry at all, to alter that, or to change, not alter, but to augment that comment, I mean, you don't want to be asked 2.5 years later in a deposition, well, if this really occurred or this additional information was available, why didn't you put it in then? Which is a bigger problem, and those types of issues that give Jenny and I heartburn at night when we have to deal with that. So
My only
I'm not a member of the
my only caveat to Dan's comments would be, don't ever make a late entry after litigation's ensued.
Yeah, that's a really late entry.
I always,
right.
yeah, I always.
The sooner the better.
You could still remember it. I mean, sometimes once the lawsuit comes in, there is clarity, and you remember something that happened. But as I tell the healthcare providers, you can always supplement your chart at deposition and say what you remember, what your normal habit, routine, and protocol is. Just because you remember it, and it may in fact be true, don't add anything after litigation's ensued. You can do that at deposition.
Right. Okay. And so, the documentation issues we talked about obviously can affect whether the case sounds in ordinary negligence and professional negligence, and this is a big deal potentially, because for those of you that are not intimately familiar with the statutory distinctions in allowing damages in certain cases. Medical malpractice cases have caps or limitations on non-economic damages, which are the pain and suffering and those types of damages, loss of companionship of family members, which are often very emotionally charged. And there's different levels of caps. We won't have to get into that now, but in an ordinary negligence case, such as an auto case, for example, there's no caps on these damages. They're unlimited. They're left to the jury's discretion. And if a certain health care related issue is an ordinary negligence case, it is a much easier task for the plaintiff's lawyer because A, there's no limitation on damages, and the need for expert witnesses is not as significant as well. And it's when we get into issues of what I would call clerical management of healthcare treatment, we are kind of getting into this uneasy potential gray zone of whether this is an ordinary negligence case or a professional negligence or malpractice case. And in a very general way, a malpractice case is founded on the analysis that the physician is using professional expertise and professional judgment. And we have had cases over the years, and Jenny, I'm sure, can talk about this with some of her nursing home cases where you have issues of or I would call paraprofessionals assisting people in walking or getting them out of bed, or issues of this nature, which are maybe closer to ordinary negligence, and it's a tussle. But with respect to EMR, I think you have yet another clerical or potentially the involvement of a non-professional, where it's not an issue of professional judgment, it's an issue of not physically doing something or putting something in the record. So that's another thing to think about. I don't think it's anything to get panicky about, but I think it's out there potentially. And
I've seen this a couple of times with just simply phoning in a prescription. The dosage is phoned in wrong, or the pharmacist hears it wrong, and if the patient unfortunately has an adverse reaction to the mistake in the script, I think it's a legitimate argument by the plaintiffs to say, that was just ordinary negligence. They phoned it in wrong, they typed it in wrong. That didn't involve any medical judgment. So it puts it, again, in that ordinary negligence category without caps, without the need to do a notice of intent or affidavit of merit, a lot of the things that we like to see the plaintiffs jumping through all those hoops. But documentation, simple documentation errors, I think it's a pretty easy argument that it sounds an ordinary negligence as opposed to medical malpractice. So you need to be cognizant of that.
then we have the benefits, and this was. We have a question?
I'll stand up. Yeah, I'm interested in knowing what are you doing to push back as, first off, physicians, because we want to do no harm. I represent a company where we don't get the results to anyone but the physician. When you get your genetic testing results back, they don't come from us. We don't get in between the physician and the patient. But we are finding, state by state, that a lot of the different legislatures are now trying to get around the HIPAA and the GINA requirements by getting the patients to sign away their rights to have that information dispersed to either the employer who's providing the group insurance or the carrier. Neither of them have access to that information now. It's strictly only the treating physician. And so I don't think we've got to that point here in Michigan yet, but I kind of feel it's coming. I don't think patients want that out in the ethosphere. I don't think physicians want that out in the ethosphere. What the results were of your genetic carrier testing or your PTX testing. So what is the happy medium that should take place on that? Because for us, our records are only available read-only if you go into the system, but we send the physician a hard copy with the suggestion that they might want to redact name and social number and use some other identifier if they're going to maintain a hard copy in their office.
Well, that opens up, that's a big can of worms, isn't it? Yeah, when you start releasing information to payers and employers, especially when it comes to genetic testing, et cetera, that does add. I really don't know. I don't have.
We don't do it, but there are some states where they are. I mean, it's a good old time right now. I think in Texas, I sourced this with two lawmakers that they just passed a law where OBGYN will not be held responsible if they withhold genetic testing results, and that might lead a pregnant woman to decide to terminate pregnancy. You can't go back and sue them because he forgot to tell you what this is now. And I'm like, did I read that right?
Mm-hmm.
If you believe that information is power, and that giving your patients every bit of information they need to decide how aggressive or how passive they want to be in dealing with the problem, that seems like we're going out a little backwards. And that seems like something that's very harmful. I thought I misread it. I really did. I want you to know it took me 3 chocolate bars with almond nuts and a whole hour of Bruno Mars to get over this, because I could not believe what I had read. And when I forced it, he said, oh yeah, that's exactly what they did. We didn't have the numbers down here to stop them. And I'm like, well, I won't be moving to Texas anytime soon, even though childbearing is way gone. That's not the point. This is the way you feel about information being given to doctors and or patients. First, you kind of disrupted that patient-doctor relationship in my eyes, and you kind of perverted it. And second off, why would you do that?
Well, it's a very interesting issue. There's multiple waivers issues. We're going to try to move along here. The benefits of the records, we've talked a little bit about this. It was designed as a savings of healthcare costs. The benefits include the reduced errors. Obviously, the legibility is a very significant point, and the access to the record will allow you to know what tests have been done. And it raises this other issue we've talked a little bit about before. Do these records really, do they really cause poor outcomes, or do they cause claims, which is, I think, an important distinction. And as one of the things we've talked about, I think, is that a lot of these issues have resulted in issues dealing with claims as opposed to necessarily bad patient outcomes or bad care. So we talked a little bit about the alteration issues, and the alteration of a medical record, whether it's a paper record or an electronic record, can trigger a sanction or a fine by the licensed physician under the statute here. And this is obviously one of the big things that we as council are concerned about if there's alterations of records. And this is a felony under Michigan law, and something that the Attorney General, I think, is very sensitive to, as well as some of the opioid issues that we've talked about.
If I could just, not to correct my wonderful colleague, but I think later on, the alteration statutes, the MCL 750.492, and that also...
That's the criminal statute,
That's the
right.
criminal...
Right.
And civil. It can impose civil sanctions up to $10,000, as well as a misdemeanor or a felony. What's quoted for you on the screen, the MCL 333, this is from the Public Health Code, and this is an allegation I see almost invariably in the licensing work that I do. I do a lot of investigations for the state. It's by the Attorney General working with your Board of Medicine, whether it's the DO board, the MD board, the nursing board, the psychology board. But this is not as so much to do with amendments or changes. This, as you see, says the physician or licensee has to keep must keep a full and complete record of tests, examinations performed, observations, and treatment made. Think about how onerous that is, the language that's used. And I'll give you a quick example of how this came to be with one of my doctors. I represented a wonderful family medicine physician, had been taking care of a patient for 20 years. The patient had multiple comorbidities, one of which necessitated referring her to a nephrologist. The patient went to the nephrologist, and she thought he was rude. She went back home and typed on the computer. As you know, anyone with a computer can file a complaint with the state. and said, I didn't like this doctor, he didn't treat me well, he didn't, So the state investigated that. But in investigating the claim against the nephrologist, the state asked for a copy of my family medicine physician's chart to try and put the story in context. The state ultimately let the nephrologist off, but in going through a 20-year record of care, found that they didn't think the chart was complete, that certain days or entries didn't include all the vital signs, it didn't include her thought process as to why she had made the referral to the nephrologist, and they sanctioned her. And we we got through the hearing, but as again, most of you probably know, investigations by the state are not covered by insurance. So this can be a very costly and painful experience for the physician or healthcare provider to get through. They're paying out of their own pocket. If experts are needed, you're paying for the expert. And it's a system with, frankly, no rules. I mean, I could talk for a day on my annoyance with the state, but it's just a cowboy system. There's no rules of evidence that you follow. There's no real guidelines or boundaries. But this MCL statute, the 333, is almost always an allegation in every licensing matter that I deal with.
But
So,
on the flip side of that, just do you think that the repetitiveness of these EMRs that we've talked about ad nauseum so far, do you think that that augments or assists a physician in terms of the completeness of the record, even though the completeness may be very repetitive and redundant?
it's a good point.
I mean-
It might be time for copying and pasting. I don't know.
So, I mean, with every problem, there's maybe a silver lining.
Yes.
Doctor?
So on that vein, that's one of the reasons why the entries are so long. Every doctor knows that 99% of what's in the notes is irrelevant except for the very bottom, last sentence. Explain that. And part of it again is, you want to be complete. The hospitals, want everything documented. Even more importantly, the insurance companies, this time Medicare.
Yep.
So in billing, when the doctor bills for a visit, there's elements in the billing, and there's a very complicated grid. There's probably thousands of combinations in that grid. The doctor doesn't get paid for the cognitive assessment of cerebral, his intelligence in assessing your problem. So let's say you go and got a brain tumor, the value of what the doctor will get paid will depend on a whole list of relatively irrelevant items, but there's tons of these items, including social history. The social history is not documented, he cannot bill at the high level. So there's and of course, the amount of these irrelevant items are so many that you really need to copy and paste to satisfy that. And so what happens is you have tons of irrelevant information to satisfy, payers. It started with Medicare, but the others are doing that too. But then at the end, what you're left with is because there's also a limited time to do that whole visit, you end up having, oftentimes missing out the old diagnosis and going through the processes. Now, I don't know if you can use it as an excuse in a trial to say, well, we just put all this extra stuff, some of it is irrelevant, it may not be correct, but we did it to satisfy some other regulatory. I mean, is there any excuse to that?
Well, it's part and parcel of why you're going to be asked questions about redundancy, and that's part and parcel of that. And it just has to be explained.
100%, 99% of the stuff is in there is inaccurate. You can't put it, of the
That's why.
Or billing, and so can Brian McKean or somebody else can say, well, you put something inaccurate, then per se you've committed malpractice.
Well, but then it becomes more of a challenge to, for the defense to, prepare appropriate motions in limine to deal with those circumstances and try to, minimize some of these arguments because they really don't pertain to the
Care.
the delivery of care. There's administrative issues or payment issues that really have not particularly critical in a malpractice trial.
So I think there's some ownership that, as physicians, we have to take in the medical record, especially when you're talking about a multi-contributory environment like a hospital, right, where you have different disciplines documenting in the same place. Things like the problem list, I guess it all depends on where you practice, but the problem list in our organization is owned by the physician. The physician owns the, so if the problem list is wrong, then it's our responsibility to correct it. And then ultimately our note, whatever we populate, because the electronic health record gives us the advantage today to pull in information that has been documented by other people, right? And when we decide to populate our note with that information, we are taking a responsibility to assume that that is correct. It's not just a matter of auto-populating and getting that information to a note. At the end of the day, I'm signing that note and saying that that information, to my knowledge, is accurate. And so I think that's where, where you start getting in these notes that are extremely voluminous and they lack relevance to your point. It's really, I think we're getting to a point now, there's some sophistication in our understanding of how we should make these notes is sometimes a little bit less is more, and making sure that the information is meaningful. And I think the EMR vendors are getting to that point as well in helping us construct these notes that are more meaningful but more impactful. And I think technologies like Dragon, voice recognition, helps to tell the story in a narrative fashion. And it helps us to carry the message across to the next person who's caring for that patient. Because if you take away regulatory, legal, and financial, the note is going to be 2 sentences. If you need it from a clinical perspective, you don't need a lot in there to indicate what you want to support in your note. But it's because, like you said, you've got to have so many bullet points from this element of past medical history, social history, review of systems, that it's kind of been indoctrinated in our way of pulling in all this information that makes the note less relevant. But I just want to make one other comment, and this is really important. And I think we're moving into a new era where we think that the medical record is only the screen that's in front of us. But in reality, with health information exchanges, which now taps us into information that is present not only at my organization or your office, but also now the availability of this information at any organization the patient goes to. Because this information now is being sourced in a sort of central place that we have access to. So as I start taking care of a patient, right, and I go into the health information exchange portal, and I see the patient had a CAT scan at a hospital down the street, and I use that for medical decision making. I need to document that in my note that I've pulled that information from another source that's maybe not in the immediate medical record that's present, because it's a federated model, which means unless I pull that note into my record, it's an external document because it's happened somewhere else. But I'm using that information to make decisions. So I'm going to have to incorporate, somehow make reference to that so that I have a way of substantiating my decision making.
Excellent point. Excellent point.
And and obviously, as I listen to Dr. Fragoli's comments, my mindset is, okay, when I would get a chart from a client, an office chart, and you'd see the correspondence from other physicians or consultants to whom the patient had been referred, or x-ray reports, or EKGs, or other what I would call off-site testing, it was all there in the record. So he had this x-ray report, he had this EKG. Well, now it's not so simple because you might not necessarily print and create that document in your chart. So again, other things that you have to now change your mindset about, both in practicing and defending these cases. We talked about the... Yeah, I'm sorry. Go ahead.
I think the biggest benefit I see during 11 years with the EHR, I think it certainly saves you time and legibility. There's no question about that. And we always complain as physicians, but there's no question. I mean, you can always have the past medical history comes automatic. Otherwise, there's so much to do. Writing, St. Joe, we have been really leaders in the last several years in the hospital. So benefit, the time definitely saves definite benefit, even though a lot of other issues are there. The benefit of saving time is definitely worthwhile for EHR.
Right, and the EMR was not designed to be a bad thing. It was designed to be a good thing, and it points out these checklists are now available and other items here. Okay, now we get into some of the anecdotes, comments, and things that come up, and we have the auto match problem when you start to type in things and the wrong drug gets kicked in. I know that there's been discussion in some of the literature on this topic about alerts, where in the hospital setting there might be alerts that come up and vendors make decisions. Vendors, many of whom are not being run by actual people that put their hands on and treat patients, creating these warnings that sometimes interfere with care. And that can become a nightmare in a litigation setting. And then we have, you have the templates that can create more accurate documentation, but they're not all the same. And you get these odd-looking charts, like the chart will say, presenting symptoms are none. And it's hard to read. It's just you're reading this note and you're saying, did this really happen, or is it just a template? And again, as Dr. Fragoli said, you have to wade through these, line after line of things that don't make a whole lot of sense to find the real meat of it. And this is something I should toss this out to the panel here, or maybe to the audience. And I've had in dealing with these issues, I have a sense that because you have a business and an industry where the software and the development of these templates is in a period where there's a lot of different vendors with a lot of different templates to do this, is part of the problem is that the software providers are so numerous, there's not good uniformity in how these EMR are prepared, or how they're generated, or how they're done. And it just seemed to me that as the industry matures and fewer vendors are then doing this, are you going to have more standardization in these templates? And it's a rhetorical comment. I don't know what the group may consider about that.
A whole slew of them will be here May 5th to the 7th in Detroit at Pecktown, Packing Health. We probably have from Canada and the United States about 40%, maybe as many as 50% of the software writers and programmers who write these programs. And they need to hear from the actual practitioners about what should be in those medical records and what would constitute effective uniformity to give you guys better records. They'll all be there, the little brainiacs, all weekend, coming up with new programs to sell to your hospital corporations. So you might as well send somebody down there and embed them into the weekend and tell them, what you really need to do your job better and not waste your time on frivolous things, so that they can do a better job creating more effective programming. Because if they don't know, it won't be in there, and they'll go to the buyers of the hospital with the next best program, and there's maybe 20% in their program you can use, and the rest of it is garbage. And now the hospital spent all this money on something that is just another new thing to put you through torture, when you'd really rather be spending time with your patient instead of fooling around with this.
Okay, so we have the issues of the templates and the dependence on those. The cut and paste issues, we've talked a little bit about that.
I would, if I could, I'd add on to the template discussion, and I see this a lot in the ER. The patient comes in and it makes me think back to the old T-sheets. Like, do you pull the T-sheet for neurology, trying to rule out the PE, or do you pull the T-sheet for a cardiac condition in case you're dealing with a dissection? And if you, God help you if you pull the wrong T-sheet, because it leads you on a path to either go think neurology thinking or think cardiac thinking. But if you're getting into the same thing with templates, where it's leading you or suggesting once it's printed that your thought process was going one way and you weren't even thinking the other thing, rule out PE, focus on cardiac. If you have a line at the bottom or a space to do anything, to type in one sentence to individualize that patient or to supplement what you were thinking with what the template restricted you to, it would be, you may save yourself a lawsuit to take the 2 minutes to type in some sort of information that individualizes that patient and shows you weren't just thinking within the confines of the template.
I couldn't agree with that comment more. It's very, very important that the free texting or the opportunity to type that in is done. And I think, I think even most plaintiffs' counsel are going to focus on that well, because I think that, some of these repetitive issues are not as significant as what that particular encounter and what the particular physician had in mind puts in the chart. Okay. We talked a little bit about the audit trails. I think we've mentioned that, and this is also the citation of the statute that Jenny was talking about before. We're kind of getting near the end here, so I'll try to get through the last couple slides quickly. We talked about patient relations, the access to data, some of the things that Dr. Fragoli has pointed out, and the access to other providers' records and how it may or may not be actually be visible in the particular physician's record, and then the privacy issues, the communications that require the passwords, and the risk of unoccupied workstations. Where, I mean, I haven't seen this in my own experience, but I could see how in a hospital setting, someone's on the screen and they not wander off, but are distracted, and then the potential for inappropriate material or inappropriate access is occurring. And I would also assume that licensing issues would come into play, because physician's assistants or other paramedical professionals would not have the same legal, that wouldn't be proper for them to do things that would be limited to the parameters of the physician.
So if I can just make one brief comment about credentials, your electronic credentials. It doesn't happen very often, but there's that temptation to, you're working with a resident or a student or whatever, and to share credentials with anyone other than yourself is a huge problem. Yeah. It's to protect yourself. You should never give your username or password if you're a clinician to anyone, because it's like giving them all of your personal information and access to your bank account, et cetera, because they when the record is printed, it looks like it's you. Mm-hmm. It is you, for all intents and purposes, and so you're assuming all of that as work that you have done. So be very careful and avoid that temptation to sometimes it's just easier to give them, especially if you're not proficient in using the electronic health record. It's just easier to give it to somebody else or let them do it. My best advice to you is to prevent that, avoid that from happening.
The doctor's absolutely correct, as always.
Thank you.
I recently attended a seminar on cybersecurity, and they said the number one best piece of information if someone's going to do identity theft is a medical record. More so than your bank statements, more so than your credit cards, more so than just having a social security number. The medical record is the number one target for identity theft people.
Makes sense.
So we need to know, obviously we've talked about what's a paper chart and what's in the EMR, and the production of records often will include both the request for EMR, and sometimes the office will have kind of two files. There may be hard copies and there may be electronic, so making sure both of them are provided. Because if there's one thing that defense lawyers, well, there's many things that defense lawyers worry about, but one of them is, did I get the full record? Do I have the full chart? Do I have everything in front of me so that I can counsel my client, prepare them for deposition or trial or whatever it may be? And I can tell you, because I've been there, is that there's nothing more disturbing at a deposition when you are finding out that there are additional records that were not provided, which may or may not be helpful. And sometimes, and this has happened, the plaintiff's lawyers will have requested the record from your client independently, and they were provided without seeking counsel, and not that that's required, and they've got stuff in the deposition that I haven't seen. And that's very discomforting. So having someone available or trained or knowledgeable, or at least someone available to ask the right questions when documents are requested is very, very important, especially in this era where the record is not always just a tangible item. So obviously, we talked about the credibility issue if the chart is not initially provided, and the designation potentially of persons trained. And I think we've had some questions, but I don't know if we have a couple of moments for a couple more. Anyone? Anyone? Okay. Very good. Thank you very much. I think it's been a good presentation. Thank you.